We are live now.
Good evening. This is Chandra Mohan, ortho physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. A warm welcome to all the participants from India and abroad for the EXRX India's and Sri Samraj Health Services Private Limited's presenting Webathon series enthusing for the world record. We will set a world record in this series in association with Pickle Studio Chennai, Sairam Academy Chennai, Dusat Creations West Bengal, powered by Dr. Venkateshayan's Stimulus Physiotherapy and Fitness Clinic, Pune, Maharashtra, India. I take opportunity today to thank all the resource persons because we have crossed 150 webinars today. EXRX India's 153rd topic is Physiology of Pain will be presented by Dr. Hariohm, founder, the Indian Center for Evidence-Based Neurorehabilitation. I welcome EXRX India team members, Dr. Rupesh and Professor Duna. Now I welcome our resource person, Dr. Hariwo, and request him to commence the session. Please, sir.
Okay. Thank you. So today we will be talking mostly about physiology, in the sense that it may not be directly applicable for you as part of your clinical science, but I think this is a vital part of physiotherapy, and also part and parcel of being a good clinician. You need to be aware of the physiology uh, very well, right? Most of our understanding of uh, pain physiology is very rudimentary, and most of us think that pain gate theory is the end of it, even though it's just a relatively small part of our understanding of pain. So today I'm going to throw light on the basics of pain physiology. I'm not going into a lot of things, especially the biochemistry of it, because it doesn't need we are not going to understand drugs and things like that. So I'm going to keep the biochemistry slightly uh, to the minimal, right? Sorry, 1 minute. Right. So I'm going to talk about the first thing I'm going to start with is the definition. This fairly simple definition. This is the older one. This is the newer one. Slightly different, but there are certain things which you have to be very aware of, right? What it means is that the first thing you want to be aware of is that it's a sensory as well as an emotional experience, right? That is vital, and a lot of people tend to forget that it's an emotional experience. I'll tell you what's an emotional experience also. Um, because you don't just feel pain, you get changes in your brain which are cognitive in nature, emotional in nature, that kind of thing. At the same time, pain can also be because of actual or potential tissue injury. Now again, this is I think this is a vital part of understanding of pain. Now, in case of actual injury, we can understand somebody gets hit and then they get pain. But if you think that there is going to be an injury, or there's going to be a potential damage to your system, then also you may feel the pain. Say, for example, if somebody is thinking that uh, they are going to get an injection, you start to get some sort of uh, pain in the you feel the pain before that itself, right? So these are the two parts of the definition you need to be aware of, because when you try to understand pain, you need to understand those things also, right? So like in the earlier webinar, if you have attended what we have done, I'm going to ask you questions and you can answer those things, right? So if it is it has a sensory part. So what part of the brain has to be activated if it is to be a sensory experience, right? You can just enter in your chat what part of the brain it has to be activated if it is to be a sensory experience. Right. So anybody else? Okay, I think the answer is fairly simple. It has to go to the somatosensory area, right? Why it needs to go to the somatosensory area, that is my next question. Am I clear? If it is a pain, what is the value of that information going to your somatosensory area? That is your sensory part of your brain. Why should it go there? What is the value of that? Can you put your answers in the chat, please?
Somebody put somatosensory.
Right, that's right. As I told you, what's the next part? Why it has to go to the somatosensory area? What's the value of going there? Why it has to be a sensory as well as an emotional experience? So what's the value of it going to the somatosensory area?
The participants kindly answer. Yes, sir. Please carry on.
That's all right. We will come to that again also, because you may not understand the questions. Now, the next part is it's an emotional experience, right? So if it is an emotional experience, what parts of the brain has to be activated? Am I clear? If it is an emotional experience, what part of the brain has to be activated? The limbic system is good. What else? What are the areas? Limbic system is one. Raksha, I think that's a wonderful answer. What else? What are the areas has to be activated? The frontal area, very good, Logeshwari. What else? Hippocampus. Okay, so there are a bunch of areas which has to be activated if it is an emotional experience. Now, why we need to understand is it's not that there is a brain pain area for you in your brain. It's not like that. It doesn't work like that. So a lot of areas has to be activated when you have a pain. That is because it is a sensory experience as well as a emotional experience. Yes, Vijay, amygdala also, but I'm assuming that we'll call it all under limbic system. Right. Anyway, so this is the question I'm going to come later on, but I'm assuming a lot of people may not have seen this. So I'm going to also show you a video of it. This is a sort of a religious function. It's not just in India. Even they do it in Southeast Asia, a lot of parts of Southeast Asia also. Can you see the video?
Yes, sir.
Right. This is what they do. They just pierce you with all over with hooks and needles, and it's sort of a religious festival. You need to go into an euphoric state to do this. Uh, there is a physiology for that, but we will not worry about those things at this moment. So they will pierce the tongue, the skin, the cheeks, and all these things. This is a sort of a common festival, especially in southern India, probably in southern Tamil Nadu. But it's also done to a certain extent, something like this in Mexico and other Catholic Latin America countries also, if I'm not mistaken. But anyway, so I'm going to ask you later on why these people are not feeling pain also. We'll just hold on to the horses until we finish this, right? Right. So as I told you, there are two parts to your definition. One is the sensory part of it, that is, it goes to your somatosensory cortex. And the other one is you are having an experience, right? And you have an emotional experience. So what does experience, an emotional experience, mean, right? That is, we need to understand that. So there are three parts to it. The first is, as I told you, sensory discrimination. What I mean by sensory discrimination is, that's why it has to go to the somatosensory cortex. What it means is you need to know where you have pain. That is your source of pain. Whether it is in my abdomen, left side, right side, that will indicate whether it is the stomach or uh, probably uh, the appendix, or whether it is, if it is higher, whether it is the liver or the pancreas, or left hand, right hand, the femur. All these things I have to discriminate, right? So earlier we were in the last webinar, we were talking about how we perceive, and then you do a action for that, right? So in that, we need to know where we have pain so that we can do a protective action for this, right? So that is the first part we want to understand. Uh, uh, the experience starts with a sensory discrimination. It discriminates between which part it is the source of pain is. The next is the affective psychology, or the affective part is, most of it is about motivation. How does it affect me and stops me from performing or makes me perform better, that kind of things, right? So if it is painful, if you're walking for 2 kilometers and it starts paining, it affects your motivation. Either you can sit down, or if it is, if you see the uh, end of your race, if you will, or the shop you want to go, or the bus stop you want to go, if it is near, you are motivated to go walk and just finish the walking, right? So that kind of experience also you get. That is what we call as the affective or the motivational. And also you love the cognitive dimension. Uh, you may feel unhappy, you may feel irritated, you may feel uh, unable to focus on these things. If you have pain, I mean, right? So all these things consist of what you have as a experience of having a pain, right? Again, this is vital for you to understand. Then only you can understand it as a whole rather than just small parts of it. Now, what's the value of sensory discrimination? As I said, it tells you where the pain is. If you can remember, you'll have your brain, you'll have your central gyrus, and then you'll have your the frontal cortex and the sensory cortex. And in the frontal cortex and sensory cortex, they will draw a inverted human being, all the parts, a sort of a map of a human person there. So it tells you where you have the pain. That's what we mean by location, how long it's been there, what's the intensity. All these things are part and parcel of sensory discrimination. For too long, this is the one part we mostly were talking about or treating or taking it as important parameters for our clinical management. If you take pain assessment also, most of it will be where you have pain, how much you have pain, how long you have pain, and things like that. Nobody talks about the affective or the cognitive part of it. Nowadays, people have started moving into it. For that, as you already pointed out, mostly the most important part is the prefrontal cortex, especially what we call as the anterior cingulate gyrus. Right. So they are also part and parcel of the frontal cortex. So these two are very important for us to perceive pain, to understand pain. These two are very, very important. So when they did fMRI, you can see that the areas which are lighting up, you can see the areas which are lighting up is the hippocampus, amygdala, the insular cortex, right? The cingulate cortex, the prefrontal cortex. All these areas do light up when you have pain, right? This emotional experience you have, it is right, right? Now, why is pain such a complex phenomenon, right? So the first question we are going to ask today is, what is the value of pain, or what is the function of pain? You can start your answers in the chat. So tell me, what is the function of pain or value of pain, if you will.
Shetal Karthi says protects from any harm. Raksha says protection mechanism.
So, okay.
Vijay T says pain is protective response from injury or any tissue further damage.
Right. So I think a lot of people have given wonderful answers, from Raksha, Vijay, Rishika, Sweta. Analyze the response. That's not how it works. Right. I think Sendil is right. It's for our survival. If you don't have pain, you will just die off. Well, die very, very fast. So as you can imagine, the evolution taught us that, or the function of evolution is survival, right? So if you have to survive, you need to understand whether you are in danger, right? Remember, we are all moving in an environment. The environment consists of so many things which can be harmful for us, to the other spectrum which can be very good for us, right? So we'll have everything in the environment, and we need to be very, very sure whether this is good for us or bad for us. For that to understand, we need to have pain. And also we need to have a pain, we need to know where it is coming from, right? And it also has to have an emotional component, because emotional component allows us to learn. Remember, the nervous system, if you cannot study the nervous system without learning, right? So the system has to learn where this pain is coming. What is this pain doing to me? Is it good or bad? Should I always have this should I always look out for these things? So there is a memory component to it. That's why hippocampus is also vital for learning also, right? So it's not from unpleasant situation. It is not protecting you from unpleasant situation. It is protecting you as is acting as a danger signal. You cannot be always having a proper pleasant stimulus. You can also have unpleasant stimulus, but it has to make you understand this is unpleasant or and this is good or bad. For that, you need to learn. That is where your hippocampus comes to play, right? So until this point of time, we have learned three things. One is the your system produces pain so that it protects you from dying. So if there is a danger from the environment which is happening to you, the pain is given to your brain, right? The brain has been feeling that pain. And when it feels three things. One is sensory discrimination. Another one is the motivational part of your and the last one is your cognitive part of it. So all these things are collectively, all these areas of to be collectively activated for you to sense, perceive pain, right? So, uh, so what we are going to do in the probably next 20 minutes is how this information reaches here from the peripheral. How does it go up there? That's what we are going to look into. So for that, pain physiology, mostly it is studied in 3 levels or 4 levels, depending upon how you want to look into it. The first is called as transduction, transmission, then the perception modulation. Perception and modulation happens sort of together, but just for our understanding, I have put it as 2 parts also. So what does transduction means? Remember, a stimulus which is coming from the environment, right? The environment can give you any sort of stimulus, whether it can be heat, it can be mechanical, it can be chemical also, right? So all these stimulus has to be changed or converted into an electrical impulse. I hope you all remember what we call as a excitatory threshold potential, right? After a particular amount of potential is happening in your synapse, then the synapse starts to fire. Then it activates your axon. So for that, you need a stimulus. That stimulus has to be sufficient. Say, for example, if you are given a hot cup of coffee, right? You're all adults, you may be able to hold it like that, right? Without thinking that, or without feeling the pain of the temperature of the cup, right? That means that you're not producing excitatory potential. But at the same time, if you're a child and if you give a hot cup of coffee, it might feel that that is a excitatory potential, right? So what it means is the stimulus from the peripheral has to be converted into an electrical impulse, and that electrical impulse has to start going up. So the first part of changing any stimulus to electrical impulse so that there is an excitatory potential, that's what is called as a transduction. So, so this is a simple way which I think can be easy for us to understand. The environment has 2 parts to it. It can produce injury or potentially it can injure you, right? So remember, if you are trying to cross the road, potentially a car can come and injure you, right? So you need to sense it before getting hit also, right? But at the same time, they may also come and hit you, and then you get starting of what we call as a tissue damage. Now, for us to understand how the environment is affecting us, we have a lot of what we call as receptors. The receptors can be many receptors. You have uh, photoreceptors in your eyes. You have mechanical receptors for your vibration in your ears, and also you have receptors in your skin, right? So these skin have receptors which can be activated by chemicals, which can be activated by mechanical, which can be activated by just the breeze which is coming out and feeling on your skin and your face, which is a sort of a mechanical stimulus also. So all these things, pressure, everything can activate, right? And if there is a tissue damage, the receptors are activated and they produce a lot of chemical changes. And that starts your stimulus or your excitatory potential of your synapse, that by activating your axon to go to your spinal cord. Am I clear? Most of the chemicals they will be most of the time talking about is 5-HT cytokines. Cytokines is a common that you might have been hearing about cytokines in the COVID also. They call it as the they are trying to control the cytokines in your lungs and things like that. They call it as the cytokine storm, which happens inside you, which if they think that if you control that, then you will get better in COVID. That is basically an inflammatory reaction. Cytokines are inflammatory reaction, which happens. You get bradykinin, you get a substance P, that's what we call as prostaglandins. All these things are released, right? So as I told you, any stimulus, it will activate your receptors, and they in turn will activate all your other channels. And the channels will, when they start opening, then your calcium chloride, everything comes in, and then it depolarizes, and then you start to conducting uh, your impulse, right? Now, why this much of importance given to the chemicals uh, in the in the periphery is these things. If you have a tissue damage, if you have macrophages which are activating T cells, all the cytokines, the bradykines, uh, the prostaglandins, all these things, they can be controlled to a certain extent via anti-inflammatory drugs, especially your common NSAIDs like paracetamol or Brufen, things like that. They can also be controlled mm, sort of very well by steroids also. Remember, all these substances can be controlled or they can be suppressed from producing via steroids also. So these pharmacopathology is vital for understanding drugs, right? But remember, this is just the starting of your pain. It is not the ending of it. And also we will understand even without this, what can happen to us. The next thing is, as I told you, we have started getting transduction, that is changes in the periphery. If I have cut here, right, there is changes here in my forearm, and they have started excitatory potential. Now it has to go from my forearm to my sensory cortex to tell that it is in my forearm, right? So that I can either move the injured part or protect it or get treatment, something like that, right? So that pathway of from my forearm to your brain is the next part, that is your transmission. Now remember, when you have pain, it's a danger signal. So if somebody comes and hits you with a stick, or comes and hits you with comes and pokes you uh, with a javelin, or comes and hits you with a cricket bat, or something falls on your foot, this information has to go super fast to your brain, right? Why? Because I have to take aversive action, right? I have to move from the danger. So this information has to go very, very fast, right? That's why we have what we call as A delta fibers. What they do is they conduct very, very fast. You can see the conduction speed is 80 to 120. So this information goes super fast to your brain, and it says that, "Oh, stop doing this." Say, for example, if I if I start doing this, right, after a particular period of time, actually, I started pressing it. Oh, there will be an information which goes to my brain and says that it'll go super fast and say that stop moving beyond that. It is going to hurt you. So it is going to give you a danger signal, right? So that's how you want to understand the L data fibers and the C fibers. If it is fast information, all these things has to be going through sort of insulated thin wires, if you will, the axons, which go super speed to your lamina 2, lamina 1 of your spinal cord, right? At the same time, if they are sort of, it is always there. If you have a headache, the pain is there, keeping on going again and again. You will get that headache halfway through this webinar also. That mostly goes through your C fibers. They are sort of without lamination or protective layer, so that they are not conducting very well. So they are conducting slowly, but because they conduct slowly, and they have a sort of a slower metabolism, they can conduct for longer period of time. So that is the first part of transmission from your peripheral to the center. Now, from the when it goes to the spinal cord, you know that there are different laminas in the spinal cord, 1 to 9. The 1 is your posterior horn cell, and 9 is your anterior horn cells. There are also other cells here. There are many group of cells, right? That's what they call it as lamina. And this second lamina right here, that is substantia gelatinosa. When the great Wall and Melzack wrote their theory, they thought that substantia gelatinosa acts as the first level of modulation. Modulation means stopping off, right? So all this information goes to your your posterior horn cell, then to your substantia gelatinosa. That's where most of them start synapting with a neuron, right? There are lots of neurons in your substantia gelatinosa, so that's why it's called as the second order neuron. From the second order neuron, here they can go to your from here they will cross and go to your lateral spinothalamic or your anterior spinothalamic. So they decussate also, and then they started going upwards as tracts. Am I understood? Now, sometimes the substantia gelatinosa itself, in the second order neuron itself, it can say that that's all right. You don't have to go upwards, right? That is, you don't have to activate uh, uh, your tracks. That is, it can modulate at this level itself. It's the substantial gelatinosa itself. Up sometimes it will not be like, it will think that okay, you don't have to start firing your brain and things like that. Let's relax, right? So that's what Wall and Melzack said, that there is certain amount of modulation at the substantial gelatinosa. It's because of the neurotransmitters which come and empty into the substantial gelatinosa. So you'll see that also. right? So, and then they move through the tracks. Mm, your probably your spinothalamic tracts, lateral and everything. Remember, everything has to go to the thalamus. Uh, then they go to three places. Now, you will also see something like this, the neo-spinothalamic, paleo, and nomenclatures like that. Neo-spinothalamic means it's newer, and paleo means slightly older. What it means is neo means it's not newer. Uh, it means that it may not be that well developed in animals like rats and things like that. The paleo-spinothalamic tract will be very good in them, but the neo-spinothalamic tracts will be slightly less, or it will not be that. What it means is you can see that your neo-spinothalamic, it's red in color, it goes up to the cortex. It also goes to your discrimination, that is your somatosensory cortex also. It also goes to your cingulate cortex, that is your frontal cortex also. In case of lower mammals, they have a smaller cortex, they have a larger limbic system, right? So the neospinothalamic tracts might be slightly rudimentary in them, and the paleospinothalamic tract goes to most important part of brain modulation, that is your brainstem and your midbrain. What are the areas they give? You can see that in the midbrain, you'll have your periaqueductal gray matter, right? You'll have your aqueduct, and surrounding that aqueduct, you'll have gray matter, right? That's what they call it as pH. So they give a connection there. You can see they give a connection there. And they also give a connection to the reticular area in your medulla, uh, parabrachial nucleus, and probably lots of places in your medulla, but these are the three important things. That is your PAG, periaqueductal duct, some amount of reticular formation, and parabrachial nucleus. You don't have to worry about what those things mean and things like that. You can read those things later on as you read more and more about those things. Now, as I said, all these things, it means is they have transmitted to your somatosensory cortex, as well as your amygdala, your cingulate cortex. So they have taken that information to get you that somatosensory experience as well as your emotional experience. So it's all gone to your brain. Remember, the brain perceives pain, not your muscle. The muscle cannot perceive pain. The brain has to perceive pain. The brain has to decide whether you have pain or no pain, or whether you have pain in your right leg or left leg, whether when you are sitting, is it painful or it getting reduced when you are sitting. All these things are decided by your brain, not by your back muscles or your ligaments or whatever it is. So that is the next part, or the last end part of it. You want to perceive and you want to modulate the pain. What I mean by modulate is change them. At the same time, it can also be an action. Remember last webinar, we said that all our theories are called as perception action theories. So if you perceive, you want to have an action. Say, for example, if you are walking on barefoot, and when you are walking, there is a pointed stone and you are stepping on it, and it is very painful, and the information goes from your foot. It activates your receptors. They go and activate your local synapse from the receptors. From there, it goes to your axon, goes up to your dorsal column in your spinal cord, from the spinal cord to the thalamus via your spinothalamic tracts. From there, it goes to your brain, right? Especially your somatosensory cortex. And after sort of probably 100 milliseconds or something like that, you will just take your leg up, right? That is, for that action you will get a reaction, right? So the body is being told that there is a danger in a form of a small thing which is pricking you. So take your leg up, right? So that is the last part of it, that is perceiving and modulation. Now, this is where I'm going to make you remember that any stimulus, mostly for pain stimulus, we call it as noxious stimulus. But sometimes a noxious stimulus cannot or will not be perceived as pain also. That is what the example which I have shown as the videos and pictures where somebody is being poked in the skin is being drilled around and they are hooked on it. All the things, they don't feel pain, right? Or they have very minimal pain. They are not going like this and pulling themselves away, right? So for that, what is the reason is always whatever information which goes in is not pain. The brain decides whether this is pain or no pain. Am I clear? That is very, very important. Not all noxious stimulus which goes up will be considered as pain. It is considered as pain depending upon the brain, what it thinks, the context, right? All these things are vital. So for the perception, you want to remember one important part of it. All these things here, the thalamus, basal ganglion, amygdala, all these parts, the hippocampus, all these areas, uh, these are collectively called here, this part of your brain, right? This is called as the limbic system. The limbic system can consist of your, you can also add your hypothalamus, but not necessarily, your hippocampus, amygdala. All these things are considered as the limbic system. Now, what does the limbic system do? So that's the next question. Can anybody tell me what are the functions of the limbic system?
So Raksha is saying control emotional responses, Dinesh memory.
Memory is not part and parcel of limbic system, but that's all right. Okay. Anybody else? Right. So what are the emotions? That's the next question I'm going to ask you. A lot of people have written emotions. So tell me some emotions which are sort of influenced or perceived by your limbic system. Regulate emotions, that's all right. They don't regulate emotions, but okay. So what kind of emotions? Okay, I will tell you a story, then you can answer, right? So you are walking on the road and it is most of the places it is the roads are very, very free, and you start walking and then there is a dog which starts barking at you, right? A street dog which you have not seen, but suddenly it starts barking at you. What are the emotions you can have? Fight and fright is not an emotion, but that's all right. Fear, that is an emotion. Okay, fear, 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 fear. Okay, that's a fear, anxiety. Very good, Rekshika. Okay, what else? Right. So, what your anger? Very good. Anger is also one of the important things you will see when a dog is shouting at you, because you are thinking, this stupid dog, I have put food 5 days back, but it is shouting at me, right? Barking at me. Now the dog here is an environmental stimulus, right? The environmental stimulus here is The animal as such, we know can bite. How did we know that it can bite? Because we have memory. We have learned that, we have seen that, or we have actually had an experience as actually a dog bit me. So you know that the dog can bite you. So what you feel is what we call as the potential danger. The dog has not bit you, so what you have got is a potential danger. Remember the definition, you can have uh, injury or potential injury. So we know that the dog is going to bite you, right? So the first thing you get is you get a fear, right? So that is your danger signal which is going in. So what are the what does your brain can do to that? It can do two things, or what is will it give reflexively or reactively? What can it give out? Please go ahead and put it in the chat also again. You're seeing a dog, and what are you're feeling the fear, anxiety, that kind of emotion you're feeling. How does your brain react? Very good, Raksha, Umesh. You can either fight or you can run away, right? That is the basic physiology you should have all studied. Uh, you can either run away, or some people might just bend down and take a stick or a stone, right? That is you're getting ready to fight, right? So this is the basic reaction you get when you have frightened. If you are frightened, how is it showing up? How is your body reacting if you are frightened? Please again send in your answers. If you are frightened, how is your body reacting? I'm not talking about increased heart rate. Even if you're fighting, it's going to go like that. I'm asking you, what will you do as such? Don't worry about the smaller parameters. We'll come to that later. We don't respond. We are responding. That is the point of it. You cannot not respond. Unable to move. That is a wonderful answer, Dr. Neelima. Sweating, freezing. Suresh, I think that's a good answer. You either freeze yourself, right, or you run away. Those are the two reactions you can have. You freeze or you run away, right? So if you have a back pain, now tell me what are the reactions you can have. Am I understood? You have seen a dog and you're either fighting or frightened. So you're either frozen or you're doing something else. Very good. Not able to move the painful area. That is basic your fright response, right? You are frozen. That is what your system tells you to do. You freeze, right? How is this happening? How is this reaction happening? That is what we are going to look into next, right? Uh, yeah, I think the other answers are also correct. So one of the first areas where your fight and fright response happens is in your limbic system, right? Your from the hypothalamus, it goes to your limbic system, and the limbic system is connected uh, sort of complicated manner. But one of the important things you want to understand how the limbic system is connected, that is, you can see the amygdala. It is connected to your frontal cortex. There is a very important connection between this and this. And they are also connected to your hippocampus, and the hippocampus, via that, it will be connected to learning and memory. Hippocampus is part and parcel of your short-term memory, and it goes to your long-term memory. That is in your cortex, right? So if I see a dog, what happens is the amygdala is the first to notice that this is a frightening thing. That is, it has uh, come to attack me. So it can give you two response. Either it can give you fright response or a flight response. How it does is it goes and activates your, sorry, it goes and activates your PAG. Remember all these areas which I have been talking about, your brachial nucleus, your PAG, all these things, they go and activate these things. They in turn activate a neurotransmitter in such a way that your system is suppressed, right? That is, remember, inhibited, right? You have two systems, one is excitatory, another one is excited. So all your inhibitory systems might come and your muscle will start not moving, it will start freezing up, right? That kind of things might happen. But we are not controlled by our emotions. Say, for example, somebody comes, he is wearing rugged clothes. Probably, if you are in South India, they are not wearing pants, probably a vesti or a kaili or something like that. And he seemed to be dirty and things like that. And if he comes if he comes and punches you, I am pretty sure most of us will not fight back because we know that he will kick us, right? So all the time, your emotions cannot be the guide which activates our action. Say, for example, you are you are just walking along in your classroom or in a marriage function or in your college day function or something like that, right? And you have you just one of the common ways we get injured is our big toe gets squished into a chair or a table, right? Now, if you're at home, we may be shouting at it or get angry and use profanity. But if you are in a classroom or in a major function or something like that, you will not start shouting like that, or you will react in a different manner, right? You cannot do the same thing. That is, you cannot do a emotional response. You can't give an emotional response. That is where we have another system, or one of the most important part of our system is your frontal brain, right? This part of your brain. Uh, Remember, that's why we have sort of a protruded forehead, which is one of the reasons why we are not fully developed when we are coming out of our womb, because we want our head to become larger, because your frontal cortex has to be larger, right? As I told you earlier, smaller mammals don't have larger frontal areas. If you see rats mostly are driven by or controlled by your limbic system rather than your frontal brain. So there is a connection between your frontal brain and the limbic system. The frontal brain can actually suppress or has a control over your limbic system. So the next question I'm going to ask you is, what are the functions of your frontal cortex? You can just probably there are 10 or 20 functions which you can write, but one or two. Remember, if you are below 25, your frontal cortex has not fully developed. Your the connection between your limbic system and your frontal cortex is not fully developed. That's why you think that you're in love with some idiot who is giving you a rose and a greeting card. You're thinking that this is the best thing that is going to happen to you. That is, you're making a lot of emotional choices emotional choice as well as decisions rather than thinking it cognitively. Wonderful, Rikshika. Impulse control is one of the most important thing. Intelligence, memory, executive function. Okay, very good. Vijay, executive function. Okay, I think that's a whole lot of answers which are good, right? So this is what you get from your free cortex, the prefrontal cortex. The most important thing is focusing attention. Uh, this is for your pain alone. Uh, Rewards, control, adjusting behavior when depending on the context. As I told you, context means surrounding the stimulus. What are the things which are surrounding your stimulus? That is what a context, right? So these are all these are all important parts of functions of your prefrontal cortex. So when you see a dog, you may be sort of you may get uh, frightened by it just in a fraction of a second. After some time, you may know what to do. You can sort of call people, or you can take a turn and go away, not see the dog, because we know that if you keep on provoking them, they tend to sort of shouting. We also know from experience, most of the dogs don't just bite that easily. They just bark at you. So all these things is the most important part of your prefrontal, and also the attention part of it. It can change your focus of attention from one part to another slightly easily also, right? So your pain signal goes to your limbic system, and the limbic system makes a decision, but that alone cannot make a decision. It has to be, that is your fright and fright response is not just by your limbic system. It also is activated by your prefrontal cortex, right? This is the reason why you have what we call as a placebo and the nocebo effect. Uh, that is, if you think that you are going to get better, then your frontal cortex will start off reinforces that, and it might inhibit your pain, or your increase your expectation, and you get a what we call as a placebo effect, right? Say for example, you have a AC room, you have a well lit room, the room is clean, you talk very well to the patient, they tend to get better with or without treatment. That's the important point of it, right? That is because you are activating your sort of your frontal cortex also. It also can happen negatively. That is, if you keep on saying your pain that your disc is gone, your bones are degenerated. If you say things like that, that can also make it worse, right? Again, what it means is that it is not just the stimulus which is coming from the periphery which makes it worse or good. As I told you, it is not just the noxious stimulus. It is how the brain perceives it that is far more important. Right? Right. So these are the certain simple things you want to understand about physiology. I have not gone into the major part of it, but just the simple part of it. And also, I just want to know about one other system, that is your pituitary adrenaline axis, right? You'll have a, that is your, if you have stress, or if you have chronic pain or things like that, uh, they can activate uh, certain certain hormones. We'll not get into that at this point of time. All right. So the hypothalamus can be activated. From there, you get ACTH is released. That in turn produces cortisol. Cortisol is sort of a stress hormone, if you will. Their major function is uh, sort of how to deal with stress, right? When you're dealing with stress, you need a lot of activity in your brain. So what it does is it will sort of all your metabolism of glucose will go to your brain. The other areas maybe not that much. So that kind of activation can also happen, and that is what they also use when you are trying to do a breathing exercise or something like that. You reduce your anxiety, and then your ACTH level will reduce, and then your cortisol will also reduce, right? So this axis also is very important for you to understand about the emotional part of your brain also, right? So those are the major parts of physiology of pain. Now, what I'm going to do is I'm going to give you 5 minutes, and you are going to think about and write it in your chat. What are the with this physiology? Uh, what have we learned, and what is the application of that in our clinical practice? Am I clear? I'm not very clear what is motor function. Uh, I'm not very fond of assessment. I'm not very sure uh, whether we need to do any assessment at all. That's just my opinion. Very good, Raksha. Emotional influence. Very good. I think that's a wonderful point. You need to make your patient understand about pain. As I told you, how do you calm yourself about the dog? We understand that the dog will not bite, right, that easily. We know that most of the time the dog just shouts at you or barks at you and leaves you alone. That is our understanding. We learn that, but your patient may not know that because he might have had the back pain the first time, right? So that is a vital thing. Patient education is uh, very important. That's also a placebo effect also you get when you are sort of calming your patient also. Very good. What else? Shweta. Uh, uh, okay. Anybody else? I understand your pain is an emotional response. Right? No, the point is, how is that going to help you in your clinical management? Remember, whatever you read has to make you better in your clinical practice. Otherwise, it has no value in reading at all. Say, for example, if you know the muscles in the foot, nobody cares. It's of no value to anybody unless and until you know how that is useful for treating your patient. Uh, okay, Vijay, that seems to be okay. Okay, that's a very good thing. Emotion also triggers pain. That's also you want to remember. Remember, it is not always top down. It's also it's not from bottom to top. It's also the other way around. Say, for example, if you're not eating properly, if you're not sleeping properly, they can also increase your pain because they also increases the level of cortisols also via your pituitary hypothalamus adrenaline axis also. So Other things like family not looking after them properly, or with that pain they have to keep on working more. So that is a wonderful answer. Don't worry about the amygdala. It's just for our understanding. Confidence and concentrate on the positive aspects. That's a wonderful answer, Dinesh. Anything else? Right. Okay. Anyway, these are wonderful answers. I just want you to give you more answers also. The first thing I want you to remember is if you are doing an exercise, you are not changing the muscle that much, because our exercise in for back pain or ONE is not it's not weight training, or it is not uh, uh, what you need to build up bulk and things like that. So whatever exercise you are doing for pain is not acting in the peripheral. Most of it is, it changes the perception of pain. Am I understood? It changes the brain, how it understands. What it understands is, see, I'm moving with the pain. I am moving. Exercise is moving, right? So see, and nothing is happening to me. That is what is happening, right? One of my friends gave a very good answer. If you want to kill the snake, you want to hit it on the head, not on the tail, right? What it means is, always remember your treatment is for the brain, not the muscle. That is why it's a joke. There are a lot of joke treatments called as MET, trigger point release, and uh, whatever nonsense you can think about the muscles. Those are not treatment, because they are not changing the muscle. The muscle cannot change, as I told you, as you have also correctly pointed out. The muscles gets tighter or looser because the brain tells it to do. The muscle don't have any energy in it itself, right? So you are changing the perception. Even in case of manual therapy, you are changing perception. You are not changing uh, peripheral aspects of it, right? You're not putting in the right place or things like that. That cannot happen. That is why I told you, in case of transduction, there is so much of chemical storm which is happening inside, right? A lot of chemical changes are happening. These work better actually with drug rather than any massage or something like that, right? And also remember, these is without any of these things we can have pain. That's what I mean by nociception is not just pain, right? So in case of chronic pain, these things will not happen. Your After your injury is fully healed, you still have pain, because
Sir, you are not audible, sir. Please check your mic.
uh, sorry, I don't know why. Can
Yes,
I
sir.
check?
Now it is audible. Yeah,
Okay.
you have put the mic behind you. That's why.
Right. So if you have uh, you can have pain without all these things happening much, right? There is the peripheral changes, right? So that is one thing you want to remember. The next thing you want to understand, that's why I told you about memory and things like that. The memory, if you keep on happening, something keep on happening, you should have learned in your first year psychology learning. You'll have operant conditioning and classical conditioning and that kind of thing, right? So for example, a lot of people say that I have pain while riding. What they mean by that is, the first time when they ride and they came home, they should have had pain, and the brain has connected riding and pain. That's what we call it as classical conditioning, has happened for the dogs in the Pavlov's experiment. When they rang the bell, it started salivating because it thought of food. Likewise, here, rather than the bell, the bike is the bell here, right? And the pain is the saliva, right? Even though it might have been because of some other reason, not just riding, there are other reasons which can causes pain. He will connect these two, and that will sort of fixate in his memory. Again, why do we need to understand this? Because these are emotional components. It needs to change your brain. You need to cognitively change it, what we call as cognitive behavioral therapies are vital to change these kind of chronic pain also, right? So that is the other part of understanding these things other than what you have already told me. And also having a good understanding of how the pain is happening, and not using complicated uh, sort of bad ways of looking at pain also is will make it also worse, what we call as nocebo, especially the common nocebos or MRIs telling the patient that you should not sit down if you have OA&E, which is an horrible idea, or showing them the MRI and showing that all the ligaments are torn away. Those kind of things are considered as very bad, because we know that that is not equivalent to pain. That's what the video shows. Even if you put a hole here, he's not feeling pain. It is not. It doesn't work like that. It is far more complicated. Am I clear? So whenever you're thinking of pain, think of understanding the brain and not understanding muscles and just the muscles and joints. Even though muscles and joints are vital, they alone cannot make you in any way understand pain at all, right? So these are the common things I want you to understand. And also you can use the same physiology, even though I've given you very small small thing. Probably take us 2 days to finish the whole thing. uh, all all our treatment, from just meditation, or if you see your girlfriend, why are you not feeling pain? Or if you have a good food, why are you feeling not, you don't feel any pain? Or if you say, for example, you go to a bad movie, the minute you get out of the movie, you get such a horrible headache. All these things you should be able to derive from what you have understood today, right? Even though I've given you a limited physiology, it should be able to do all those things, right? So that's my talk on pain physiology. If you have any more questions, I'll be happy to answer also.
Thank you so much, sir. We will go for question and answer session.
Right.
Dear participants, either you can type or raise your hand. The YouTube viewers also, you can write your questions there in the live chat box. We will copy the question to Zoom meeting. So when you were talking about that dog and fear, recently a video is in trending for past 3 or 4 days. A small boy was sitting at 1.5 years, 2 years old boy sitting on the ground, and a small puppy is pulling his shoes.
All right.
He tried to escape.
Yeah, I saw
He didn't have fear. So he politely hold the cheeks of the dog and he bite the ear of the dog, and dog got the fear.
Now, one of the important things we want to remember is also that millions of years of evolution also has taught us a lot of things. I think that boy that is not the normal, right? That's why we find it very funny, because the fear of animals has been in our genes. It's in our genes. It's been passed down for years and years, millions of years. So even though it's a good thing he had a fight response rather than a fright response, most of us will have a fright response, because for millions of years we have been uh, we think of animals as things which can hurt us, especially if they have canine teeth, right? The teeth which are longer. That's why we are not afraid of cows, even though they are huge. We are not afraid of it because they don't have canines. So we need to remember that also. Okay. You said exercise changes the perception of pain. It doesn't really reduce pain by doing such as MET and trigger release. They don't reduce anything, because the first thing you want to remember is the muscle is in spasm or contracted, not because the muscle has some energy. That itself is a wrong terminology. The PAG and the other hormones released from the brain tells your muscles to go into a spasm, right? So when they are doing this, whatever treatment you're doing, if you think that you are relaxing the muscle by releasing it from this and that, that means is leave alone whether it is reducing the pain or not. That is not the question, because that's a different type of question. The physiology, what they are saying is wrong. It cannot be, because that's not how the brain works. And in case of trigger, there's nothing called as trigger point. The woman who wrote the book, Simone, whatever her name is, I can't remember her name. She herself couldn't find trigger points. She just wrote a book, and everybody is practicing it. That when we studied physiology or or even when you are studying pathomechanics or pathology, nobody will study about a trigger point. You will study it as tender points, right? If you have appendicitis, you will have a tender point over here in your stomach, right? In your abdominal region. So that means that you have a tender spot. So thinking that all these chemicals are inside the muscle, they are waiting there to be released by us, that is just a nonsensical physiology. Nobody has ever shown that physiology to be happening. It cannot. Your body will not store chemicals like that. We have mechanisms where we have to take away the chemicals away. We have to come to homeostasis, phagocytosis. All these things has to happen. You cannot have these chemicals being stored here and here in your muscles, in that muscle, this muscle, 10 triggers in your trapezius. That is not possible at all. I really, really don't understand how these things came into play. Anything else? Okay.
Yes, sir. Is there any questions in YouTube? Rupesh, can you please check? Duna madam?
Questions in YouTube, sir.
Pardon?
No questions in YouTube.
Okay.
Please forward the questions, please, to
No
Zoom
questions,
chat.
sir.
No questions. Okay. Thank you so much. Thank you for the opportunity to talk to you all. Thank you so much.
Thank you, sir. Thank you so much. Thanks for your time and the valuable information. Sir, final question. What are the chemicals released during in
Meditation and all.
meditation?
Right. As I told you, when you are stressed I'm not going into a lot of meditation. I really don't know of understanding, but simple. As I told you, there is a axis pathway called as the pituitary hypothalamus adrenaline, which activates your ACTH, and then from there your cortisol. It's a complex chemical reaction you will get. If there is so much of cortisol, remember, cortisol is a corticosteroid, which we put it for reducing our inflammation and things like that. If they are so much in your blood, what it does is we get adaptation. The chemicals don't work. The cortisol does not work, so it does not heal you. So what we think nowadays is calming yourself via meditation, or what we call as what's that therapy called? Okay, sorry, I can't remember that. So those kind of treatment, what they do is they reduce your anxiety by activating your frontal cortex, as well as your pathway, your pituitary hypothalamus adrenaline pathway can also be modulated. Your cortisol levels. Mindful meditation, very good. Thank you. So those kind of things will reduce your cortisol levels, so that your anxiety also get reduced. That is just one part of it. There may be a lot of other pathways. I am not very sure of those things.
Thank you, sir. There is one more question from Professor Satiraja.
Okay.
Neural pain tracks in brain.
Neural tracks are similar to what I've been talking about. Say, for example, when two areas are activated, right? Say, for example, as I told you, when you are when you see a, for example, when you see a chair, right, or when you see a workplace and you go and sit there and you start feeling pain. A lot of people tend to say that when I finish my when I go to the kitchen and finish my work, I don't have pain, but when I sit down, I have pain. So what it means is there are 2 or 3 areas which are activated together, right? That's what they call it as tagging, that these two are activated together. And that will that's what we call it as the neuromatrix theory, which is the advanced version or the newer version of pain gate theory. So if somebody is wanting to read about those things, you can go and read Melzak's newer theory, which is called as the mm, neuromatrix theory.
Thank you, sir. Thank you for patiently answering the questions. And I thank all the participants for their support and contribution for the EXRX India's webathon powered by Dr. Venkateshan Stimulus Physiotherapy and Fitness Clinic, Pune, Maharashtra, India. Good night. Bye bye all.
Bye.